for the organizers for this opportunity to speak about something that I do a lot, but not so much in the young. And when I was asked to give this talk, I went back to the data we have and found 30 patients that were followed up for 10 years. The last one was 2 months ago. And I spanned the ages to 30, otherwise I didn't have enough. 7 of them were under 18. And these are the diagnosis. You can see it's a difference than the older group in the sense that we have less osteoarthritis, but we have a lot of osteonecrosis, AVN. Basically, it's because of the children that are treated with steroids to myeloproliferative leukemia, and they get this osteonecrosis that I will show you later. And I thought, what should interest pediatric orthopedic surgeons in my field? And probably it's not the technique, even though we have one arthroplasty surgeon here, Professor Reis. But most of you are not familiar and not interested in the technique things about total hip. And I went back and thought to myself, what was interested for me? What was unique for me dealing with this specific population? And the first question was when to operate. Because maybe it's very common for you people, but for me to sit with a child in the room, which is the patient, with a parent or 2 parents inside, it wasn't something that I was, practicing. Who do you talk to? Who do you address? Who makes the decision? So that was my first encounter when I first saw this 15-year-old in my office. And the other question, which is difficult to explain to the family and to the other doctors, what about survival? How long will it last? What happened next? So these are the unique things, I think, and I will be happy to answer you. So this is a 15-year-old girl having some skin collagen disease treated with steroids for a few months, developing avascular necrosis, osteonecrosis on her right femoral head. She's in her first year at high school. She cannot walk. She cannot participate in the activities at school. She's 14 and a half when I first see her. And I just, I was shaking to tell her she needs an operation. I don't show you the MRI, but it was a huge avascular necrosis of the head. And I said, let's try another conservative option. I sent her to hydrotherapy, apostherapy, you name it, and asked him to come back at 6 months. They came back at 3 months and said she cannot do anything. And this is her. I don't know if you can see, but this is her. She was born in January 2002, and this is the date of the operation. So she's 15 now. And I planned on the affected side and the non-affected side, and decided to go along with this operation. And that's the final result. That was 2 years ago. I saw her a month ago. And she's cured. She's like much, much better than she was before. So they made me decide for them because they said she cannot keep on going like this. And this is another patient. She's almost 18 when I saw her. Again, leukemia treated with steroids. Very long period of time disabled. You can see the advanced collapse, avascular necrosis, not like in the first case I showed, but here we see collapse. And if you combine this with disability and pain, the recommendation for surgery is easier, even though it's an 18 years old. And I remember raising her as a resident, working with Professor Halperin. He would postpone anytime he could operating on this kind of patients. But in this case, again, it was an easier decision. That's her axial frog position. And this is the operation. So what we do is we operate on what is called the anterior approach, when you position the patient supine, and you can use fluoroscopy very easily. You can see this is the reamer preparing the acetabulum on the left side, and if we're satisfied, we can go on putting the cup and move. You can see the brooch within the femoral canal over here. This is not the final prosthesis. This is, again, fluoroscopy. Cup is the final one. And this is the final prosthesis on the left side. Now the cup on the right side. So we did a bilateral, simultaneously, total hip replacement using ceramic on ceramic because of the age. And this is her first follow-up within 6 months or so. But these kids, as you know better than me, have more than one area. You can see the avascular necrosis over humeral head, and this is the talus. So if we can relieve them from the hip joint, it is very important. This is a 20 years old lady, female, training to be a nurse, 10 years suffering from some inflammatory disease, having all the drugs for that, Humira at the moment. She's planning on finishing her training and getting married. She's going to get married next month. And that's, and we decided not to do it simultaneously because the left one was more affected, and this is 4 months ago, what you see the left side, and I just did the right side. I don't have the x-rays. 2 weeks ago. This is another case of osteoarthritis for unknown reason. You see the MRI showing the collapse, and that's her final result. And this is a male. He's 21 at the moment. You see dysplasia, but he doesn't have a narrowing of the joint. So I didn't want to operate on him, but he was complaining of mainly two things. One, that he was short on this side, and this is not an indication for me, even though I had many years ago, 26 years old, post-Perthes, when he was 12, and he was short like 4 centimeters, and he said, I asked him, do you have pain? He said, well, I do have pain, but my main problem is that I cannot pick up on girls because I feel like a cripple. And we made a consultation with everybody and decided to go on with the surgery. And then he was lost to follow-up. I went with my wife 3 years later to a restaurant, and he was sitting outside the restaurant smoking with 2 girls. And he said, doctor, we made it, right? But this is another guy, narrowing, so I injected his hip under fluoroscopy with lidocaine. And He had immediately relief, so we went on with surgery, and he's like 4 months. And sometimes we have more difficult cases. We're doing all cases through anterior approach. This is a DDH using a modular prosthesis. Had to have a screw to fix the cup. And this is a more difficult DDH. This is what we call a Crow 4. This is a high dislocation, 6 centimeters short on the left side. So you cannot bring it back without doing a shortening osteotomy. So we start with the cup and then put the prosthesis in and do the osteotomy. Bring the end of the stem inside, reduce the osteotomy, and cover it with the osteotomized piece. He's short 5 centimeters, and altogether the leg length is equal. This is another advantage of the supine position, where you can measure the leg length at every stage of the operation. So we had so far no major complication and yet no revisions. But what about follow-up? If you look at the literature, and this is just, there's not a lot of published material, but this is a study comparing young total hips to old ones at a minimum of 10 years, average 13.6, and the 14 survival was almost 95% for the young group, as opposed to 98% for the older group. This is older than 60. So follow-up is probably the biggest problem we have. Survival, and again, when we do the revision for this group, we lower the survival rate. But I think that total hip, for these patients, that you exhausted all conservative options, is a valid option which you can think of. And I thank you for your attention.